So I just have one disclosure. The only one disclosure is that the Nestle grant the project. So I have to change the slide.
Okay. Thanks.
Thanks. So we'll talk about a little bit about the heart failure. We'll talk a little bit about the ketone and the heart, and after we'll talk about the project. What you have to know first is that the cancer, so that line is the cancer problem, so the mortality with cancer. Now, the first cause of mortality because the mortality for the heart decreased. So the heart for the cancer, we die about the same for the cancer, but with time, the mortality for heart decreased. It decreased a little bit about the health care that we give, a little bit because of the health habits that we have. So now the health habit that we have is better. We population smoke a little bit, but less than before. Now it's 20%, before it was 70. So it's better. We eat better. We don't eat as we supposed to eat, but it's better than our grandfather or grandmother. So now the health for the heart, we die less for the heart, a little bit, the same for the cancer. And for the heart, what we have to understand is that mainly the heart problem, we die from heart failure. So for the heart, we have the beginning, we have some high blood pressure, problem with the blockage for the heart blockage, coronary stenosis, but at the end, normally it's the heart failure. And what we have to know is in Quebec, so if we take the numbers from Quebec, in Quebec we are about 8 million persons. The health cost for heart problem is 3 billion. But from that, 11% of person with heart problem have heart failure. And these 11% take 40% of expense. So the heart problem for the heart failure is one of the problems that we have to look for, not just for the health of people, but also for the health budget, the health care budget and the province. The guideline for the heart failure, what we have to know is that now we have the first line, maybe that is very small, but the first line is the medication that we have to give for people with heart failure. So medication to decrease the blood pressure. ARNI is a medication that works on the renin-angiotensin system. Beta blocker decrease the drive of the adrenergic drive. MRSA is aldosterone. So we decrease the pathway of aldosterone, and since maybe 5-10 years, SGLT2 inhibitor. It's because of that last treatment that I show you the slide. Normally, what we have to show, if we want to give a new treatment for heart failure, we have to show that it's better than all that, because every step that we give increase the strength of the heart by 7% and decrease the mortality. So if we want to it has to be on top of all that, because we don't take off one medication that decrease the mortality. So if we want to show something, we have to do on top of that, or we have to show that the treatment works not at the end stage. We have to show that the treatment worked before. But because before, the treatment that we have just decrease the hospitalization or don't decrease mortality for the majority of treatment, except for heart attack. So we will discuss a little bit more about the last treatment, the inhibitor of SGLT2 that work on the kidneys. And if you look at the picture, it discusses many things on the body, but things that we have to know. That treatment increase the ketone by the liver and increase the ketone by decreasing the ketone that go out by the urine. So it's work on the kidney and work on the liver. So that medication increase a little bit the ketone in the body, a little bit, and I will show you that with the study that we made, the study that we made increased the ketone at about the same level that the medication worked. So it's interesting that we have around the same kind of level. So we have to know that. So we'll talk a little bit about the ketone for the heart. The ketone for the heart reduce oxidative stress, improve endothelium function, and modulate a little bit inflammation and the sympathetic activity. So the same way as we give some beta blocker to decrease the sympathetic activity, but the ketone do a little bit the same thing. Not as much as indication the beta blocker, but a little bit the same thing. I discuss all that is for people who have reduced heart failure function. So they decrease the strength of the heart, but we know since 3 to 4 years that the ketone, the inhibitor of SGLT2 work not only for people who have decreased heart function, but also for people who have heart failure without decreasing the heart failure function, because half of the patients who have heart failure have decreased function of the heart. Other people have normal function of the heart. The heart is not as, are a little bit more sick, and their heart failure, but the medication, the SGLT2, is the first treatment, the only treatment that works for people who have normal heart failure function. And maybe a part of that is because of the ketosis. And for now, it's only way to treat people with heart failure without decreasing heart failure function, without decreasing the strength of the heart. So it's the only medication except for diuretic. If we give diuretic is the keystone. If you have heart failure with fluid on the lung, diuretic will work to decrease the water. So that's a slide to show there's not a big difference, but it's a difference enough to decrease the hospitalization and the problem for them. So for non-normal condition for the heart, in normal condition, ketones are responsible of 3 to 5% of the ATP production. And if you increase the plasma ketone, the heart will take the ketone and will take that. So I have some slide, not that, but some slide that if you increase the ketone in blood in regular normal state, the ketone will go in the heart cell. So we know also that if we give ketone, we suppress myocardial uptake of glucose and suppress fatty acid oxidation. And the problem that we have is that the model for the heart, maybe that's not right for the rest, but for the heart, we know that the animal model or for the ketone are not right. We know that is very, very different for the heart. So if we are able to do study for the human and not for animal, because we know that the study for animal for the ketone are the reverse, it's not exactly the inverse for many cases for the heart. So we know that for the heart failure, so in many other situations, the animal are not only the same, but for heart failure, if we are in heart failure model, if we in normal, not normal, in heart failure model, the heart would use a little bit more the ketone, the same as dedicated. And so it's a slide that show a man of 1950, but this is ultimate. So men of 2020, but without overweight, without overweight. But we know that if we are overweight, the amount of ketone in the blood and the amount of ketone that the heart use will be a little bit higher. And if we are in heart failure, there will be more ketone in the blood, and also the heart, because the heart will take the ketone in the blood. If there's more, the heart will use a little bit of ketone as the fuel for ATP. So it will be the way to use the ketone a little bit more. And we know that maybe that if we give more ketone, maybe that it would use a little bit more. And the heart, maybe that it do that because he want to correct the problem that he has. He want to preserve the energy, so he shift the metabolism from fatty acid and glucose to ketone, and he do that by himself. Maybe, and the question is, if we give him something that by himself he find it easier to take it for himself to buy a fuel for heart failure fuel. Sorry, thank you. So there, there's two studies. Before that, we'll look if we give ketone with for heart failure patient with reduced ejection fraction. Two study, one study of 24 patients with ultrasound, so heart ultrasound, and one study of 12 patients. These studies are not able to look at the volume. The ultrasound are not enough accurate to look at the volume. They just is acute effect of ketone on heart ejection fraction and about some blood pressure. The ketone increase frequently high blood pressure and the heart beat fast. So here's the slide. I don't want to put in the slide, but there's many measurements they do, but not the volume. Because if we want, so it's the same for the second slide. So the increase, the first in the side, the screen. So that side of the screen. The first thing you show that there's increase of ketone in the blood, but the others all the same way. The increase of cardiac output, increase of ejection fraction, and but just one dose. So it's one dose of ketone to that they did ultrasound. The problem is if we want to do a more bigger study, if we want to pass from giving ketone just one time and do measurement and to give ketone every day and do measurement and increase the heart function for the long term, we have to pass by a study from with MRI or with the nuclear medicine test, ventricular. So to be more accurate than just ultrasound. So we do that, and we did that, and we had a problem with that. I will explain the problem that we have. The results are the same, so that I will show you that the heart, that the function of the heart is better with ketone, but to do the measurement, to give the ketone, to do the study, the logistics of the study is very difficult. It would be very difficult to do a study. So it shows the pitfall that we have if we want to do a more biggest study for them. So the study worked. We have 20% and the study, the results are positive, but it takes 2 years to do that, to have 20%. So the goal will be to be better with the design of the next study to include more than 20%. So the study, so Alexia, so there's many people who work for the study. Alexia is a medical student. Roxanne and Gabrielle are fellow. Etienne, that you know Etienne and Gabrielle. Gabrielle and Dr. Cario are two radiologists. So Samuel Lamel is a statistician. Steven, Bernard, I don't know, Bernard is a scientific for Neste. And so there's many people who work for 2 years for the study. What we have to know is the study compare a ketone plus another project. And the other arm is placebo. The other product is, sorry, I have trouble to change the slide. So the other product is NAD precursors. So it's a kind of B vitamin, B3 vitamin, niacin. So it helps a little bit for the repair of DNA, and it's helped for a carrier of electron. So it's the medication that the patient receives contains a ketone with that versus placebo. So we select a person 18 years older with ejection fraction below 40 with class 2 to 4 heart failure, same medication, so since 7 days, because maybe that for the heart failure treatment, we increase medication every maybe once we increase the medication. To have the gold standard medication, the 4 medication that I show you, we increase the medication every 1 to 2 weeks to achieve the more highest dose. So, but for the study, we want people who have the same medication for 7 days. It was very difficult to have that steady state because each time that the patient see a doctor, they increase the medication. So same medication for 7 days, and we exclude diabetes. And we know that 40% of birth who have heart failure have diabetes, but we have to exclude the confounding factor. We exclude chronic kidney disease, a part of because of the trial, but so we exclude that. So it's half of person with heart failure have chronic kidney disease. So it's a problem for that. And we exclude person with contraindication to MRI. So people who have defibrillator, they are excluded. So more than half people with heart failure have that. So you understand that if we want to recruit, you don't have to guarantee that to get function, and they don't have to have defibrillators. So it selects a very small part of the population. If we want to do another study, because I think that we will have to do another study, we will have to think about a little bit more all the people that we exclude at that point. So the design, so it's blind, all design will be blind. The people, the person who do the study, the patient, and the person who read the exam. So it's completely blind. And it's a crossover. So one time the person have the ketone, and so scan, MRI, ketone, or placebo, MRI. And the next time that the person come, maybe 2 weeks after, MRI, ketone or placebo, and MRI. So all patients have 4 MRI. So baseline, ketone or placebo, another one, so 4 MRI. So with the cost of an MRI, you understand that the cost of the study is mainly there, not for the ketone, it's mainly the cost of the MRI. So pretty small, but is the patient that we recruit is mostly male, but mainly heart failure patient are mostly male. So age 68 it's normal to have that. So all that is normal what we expect from heart failure patient. And the ejection fraction, 30%. So if I don't know if it's working.
Just work on that screen.
Okay, so the heart failure, the ejection fraction, 31%. So it's not very low because we have to understand that people who have defibrillator are excluded because we have to do MRI. So people, when the ejection fraction is very, very low, we put defibrillator. So it's a study about people who have a little bit more than 30% of ejection fraction. Most of the people have between 30 and 40. So it's not severe heart failure, it's moderate heart failure. We have people in class 2 that, so when some people in class 4, when they feel the questionnaire of the study, you remember that they were in class 2 when we include this patient. It means that the situation of this patient with the treatment that they receive, they get better with the treatment between the randomization and the time that we do the scan. And the treatment, it's normal to have that kind of numbers for treatment for heart failure patients. So 85, 90, 75% of person have the heart failure medication. So that's according to the guideline. And for the SGLT2 inhibitor, 60%. So that's not very high, but you remember that these medications are added to the rest of the. So that's very small, but that slide shows that there's um, that's line shows that line is the Egyptian, that line is the placebo. So as we expect, the ketone increase when we give the ketone, and there's another thing, when we give the ketone, the glucose decrease and the insulin decrease also. It's the other way for the person who have the placebo. This slide I will show in the graphic because maybe that's very small from the other side. So I will show you in the graphic. So if you look at the first part, you can show a left ventricular ejection, left ventricular and systolic volume. So it's a volume, left ventricular and diastolic volume. So the volume decrease. The volume for the left ventricle decrease, the stroke volume decrease a little bit. And the left ejection fraction decrease, but for the placebo, it increase, but for the placebo, it's decrease. So the difference, we look at the difference because between the placebo and the treatment. And we did a measurement that we correct the ejection fraction for the heart rhythm, the heart rate, and for the blood pressure. And there's a big difference between the two. So that's the result that we have. So the slide of the result is mostly that slide. So you see that for the volume, there are significant the difference between the placebo and the ketone are positive. So we want for the heart to be better to decrease the volume. So we want the volume of the heart to be a little bit smaller. We want the ejection fraction to be higher. So it's not significant, but almost significant, but we want this result is what we want for the heart. For the right side, it's very difficult to look at that with the echo, but the heart volume decrease with the ketone, but decrease also for the placebo. So we don't have difference for that. So the difference that we have are on the side that the ketone work for 20 patients. So it's for 20 patients for the heart failure to increase one dose to increase the function of the heart. We look for you remember 12% have SGLT2 inhibitor, but if we look, there's no big difference, not enough to be, maybe one thing, the diastolic volume that decrease a little bit more, but it's just 12%. Maybe that there's no evidence that there's a difference with people who have or don't have SGLT2 inhibitor. The hypothesis about how it's work, because it seems to work. And if it's work, if you have to remember that each pill that we give costs $1 to $8, $10 a pill. So all these patients have a combination of medication that costs maybe $40 to $50 every day. So if we have something that add on that, help these people and help a little bit the cost of the heart failure treatment, it would be good. So the result, maybe that is related to hemodynamic parameter. So if we look at the small graph, ketone increase blood flow, increase contractility, increase vasodilatation, and the dilatation, if we increase dilatation and contractility, reduce end systolic volume, and it could improve ejection fraction. The limitation that we have, we exclude diabetes. So that's a big part of heart failure patient. We just have a small sample size. So 20 patients is not very high, but it's more than many studies before. We have, because of the MRI, exclude many patients. The patient with defibrillator, we exclude them. And it means that we have less severe heart failure per patient. So the decision, next two slides, the concentration of ketone is less than with other studies. But in our studies, the concentration in the blood is less than other study, but it's a little bit the same as I told you that with the SGLT2 medication that we know that work to increase the strength of the heart. It's an acute effect, but is not what we want. We want an effect for a person who will take that for many days. And we want to increase the strength of the heart for many days, not just for 2 hours. For 2 hours, and during that time, we do a scan. So we want the effect to be chronic. And up to date, we just have study for the heart failure for just 1 dose. So next step is to have a bigger study with a design that we will be able to include more of the patient with heart failure. The design that we will have not just an acute dose, but a dose that will be more the real life. So the real life is to take the medication for many days. So you will be you will improve the person not just for the day, but for many days, and for the time that they will go shopping and do the regular life. And we want to identify some subgroup will benefit more of the dose of ketone. Maybe the person without HLT2, maybe people have the medication, maybe people that we take a blood test before the study and we look and they have medication, but the level of ketone are very low, the level of insulin are low, high, I don't know, but we have, maybe that the medication will work, the ketone will work more on some subgroup of patients with heart failure that we have to identify before doing the other study. So, and we remember that this person have 4 medication, but 4 medication is the gold standard. But with diuretic, aspirin, because they have some heart problem with stent or coronary artery disease, statin, because they have high cholesterol. So these patients have not just 4 medication. Normally, these people have 8 to 10 medication minimum. So we have to understand that we will try that medication on top of 8 to 10 medication. So it will be a big problem to be sure that there's no interaction, to be sure that to have the subgroup analysis. So thanks a lot.